Good evening, everyone, and thank you for joining us tonight. My name is Karen Brownlee, and I am the Adult Program Coordinator at the North Suburban YMCA in Northbrook, Illinois. In that role, I bring a variety of programs to adults in our community, including social networking opportunities, a caregiver support group, brain games, and the YMCA Education Series, which you are attending tonight. It is my pleasure to welcome you to Illinois Bone and Joint Institute's 12th virtual education series with the North Suburban YMCA. Tonight's program, entitled Healthy Bones and Osteoporosis, will be hosted by Dr. Alejandro Rodriguez Paez, and she will discuss osteoporosis and bone health with us. Dr. Rodriguez is board certified in rheumatology and internal medicine and specializes in diagnosing and treating musculoskeletal disorders, including rheumatoid arthritis, osteoarthritis, psoriatic arthritis, lupus, gout, Sjogren's syndrome, ankylosing spondylitis, osteoporosis, vasculitis, and other connective tissue diseases. However, she has an admitted passion for osteoporosis and bone health. Born in Colombia, Dr. Rodriguez speaks fluent Spanish and ranked first among 153 students in her medical school class at Universidad Nacional de Colombia in Bogotá, Colombia. She completed her residency in internal medicine and her fellowship in rheumatology at Albert Einstein Medical Center in Philadelphia, Pennsylvania. Dr. Rodriguez works closely with her patients to develop effective, highly individualized approaches to care that may include medications, physical therapy, exercise, diet, and more. Regarding her philosophy of care, Dr. Rodriguez says, "My patients mean so much to me. I'm dedicated to maintaining their function and well-being through close, long-term relationships based on communication and respect." Thank you again for joining us this evening, and thank you, Dr. Rodriguez, for taking the time to discuss healthy bones and osteoporosis. And please take it from here.
Thank you so much for that kind introduction. Good evening, everyone. So today we're going to talk about osteoporosis and bone health. So first, I want to discuss what osteoporosis means. It is a skeletal disorder that is characterized by low bone mass, and it causes a structural deterioration of the bone tissue that leads to bone fragility and an increased risk of fracture. A common misnomer or misconception rather than the patients have is that this is the same as osteoarthritis or similar. They're two different conditions, but they sound the same. So osteoporosis is an asymptomatic disease. The symptom of it is a fracture. What is an osteoporotic fracture? So it's a fracture that happens from falling from a standing height or less with minimal trauma. It is important to know that the bone strength has two components, the bone density and the bone quality. And at this time in clinical practice, we can only measure the bone density. It's important to know that the osteoporosis is very common. We know that 1 in 2 women and up to 1 in 4 men over the age of 50 will break a bone due to osteoporosis. It can also be deadly. We know that about 300,000 hip fractures occur in the United States every year, and about 25% of those patients can die within the year of their fracture, their hip fracture. We know that about 25% end up in long-term care facilities, and about 50% of those patients never regain their baseline function. We know that women's risk of fracture is equal to their combined risk of having uterine and ovarian cancer, and a man is more likely to break a bone due to osteoporosis than he is to get prostate cancer. It is also a very costly disease. We know that in the year 2018, about $52 billion were spent in costs related to osteoporosis treatment, not only for the patient, but also for the healthcare system. And it is expected that by the year 2040, about $95 billion dollars are spent annually treating this disease. So we know that it is treatable, if not preventable. We know that a patient that has had a fragility fracture has a very high risk of having another fracture within the next year. And we know that about 50% of those repeated fractures can be avoided with treatments that we have currently that are cost effective and well tolerated in general. We know that about 200 million people worldwide have osteoporosis, and about 54 million men and women in the United States have this disease, and this is responsible for about 2 million fractures per year. We know that the prevalence rises from 4% in the decade of the 50s to 52% in patients that are older than 80 years old. Earlier in life, around 50s, patients tend to have more wrist fractures, and as they get older, in the decades of the 50s to 75, they get vertebral fractures. In the late 70s, they can get hip fractures more commonly. As I was saying, having a prior fragility fracture is associated with an about 86% increased risk of a future fracture within the next year. There is this saying, fracture begets fracture, so it's very important to try to diagnose and treat these patients. Despite of all this, we know that about a third of estimated cases of osteoporosis are diagnosed currently, and about a seventh of the women with osteoporosis in the United States are treated. So I'm going to switch gears and discuss the types of fragility fractures that are more common. The most common ones are the vertebral fractures. So we know that these fractures can happen with everyday activities such as lifting, pushing, pulling, or sometimes even coughing, or with simple falls, and about 30% are diagnosed clinically, meaning that a lot of them are asymptomatic. The consequences of these fractures, they can cause chronic back pain, they can cause loss of height, and they can cause deformity. Patients can be curved, and that can cause a prominent abdomen that causes problems with breathing and reduced pulmonary function. Also, patients can have loss of self-esteem because they have distorted body image, and they can become dependent to pain medications, have problems with depression, sleep disorders, and they have loss of independence because they have very poor mobility. And these fractures also increase the risk of mortality, of dying. And then the hip fractures are the second most common type of fragility fracture. They're usually caused by a fall from a standing height. And here in this picture, we can see the mechanism of falling and fracture. About 1% of the falls lead to hip fracture, and most of these patients require hospitalization and surgery. As I was saying before, it's very important to know that within the first year, about 25 to 30% of patients that suffer a hip fracture can die from this fracture. About 50% can become permanently incapacitated, and about 25% require long-term nursing care. The third most common osteoporotic fractures are the wrist fractures. They usually happen after a fall with an outstretched hand, like we see here in this picture. Patients that have this fracture can have also chronic pain. They can have temporary or chronic disability, and this can lead to degenerative arthritis and difficulty with handwriting, dressing, and others. Switching gears, we're going to talk about the multiple risk factors for this disease. So we know that white females are at a higher risk. Also, females that or patients in general that have a small frame. We know that our risk increases with age. Patients that have early menopause also have an increased risk of osteoporosis and bone loss. Patients that have problems with their menstrual cycle or that have eating disorders such as anorexia. Smoking also increases your risk of having bone loss as well as having significant alcohol intake. It's very important to know that genetics also play a part on this disease. We know that patients that have a family history of osteoporosis or a fragility fracture in a first-degree relative have a higher risk. Patients that have low body weight, which is a body mass index less than 20, and vitamin D deficiency. As I was saying before, a patient that has had a fragility fracture has a higher risk of having another fracture. So it's very important to take that into account. Patients that have frequent falls for different reasons, dementia, problems with their vision, difficulty ambulating, or lack of balance also have an increased risk of having these fractures. Many diseases are related to osteoporosis. As a rheumatologist, we treat autoimmune disorders, and most of our diseases have an increased risk of osteoporosis in addition to the medications that we prescribe, mostly steroids. Other common medications that are related to this disorder are the proton pump inhibitors, or the medications we use for heartburn that are over the counter currently. Many other medicines such as heparin, medicines that we use for seizure disorders, and narcotics are also implicated in this disorder. Multiple endocrinological disorders such as hyperthyroidism and hyperparathyroidism, cancers such as multiple myeloma, other gastrointestinal disorders such as celiac disease, Crohn's disease, ulcerative colitis, or having had bariatric surgery increases the risk of osteoporosis. And patients that have kidney dysfunction, HIV, COPD, or also that have had organ transplantation. So as you see, there's a lot of risk factors that we take into account, and everybody is different depending if they have one or multiple risk factors. How do we diagnose this disease? So we use DEXA scan, and probably many of you have heard of that. It's a machine that uses X-ray technology that gives very little radiation exposure, and is a very inexpensive test that helps us measure the bone mineral density. As I told you earlier in the talk, it's very important to know that the bone density is one of the components of bone strength that we measure. The diagnosis is made based on the lowest T-score, and we measure the areas, the bone density in the lumbar spine, in the hip, and in the distal forearm. It helps us with diagnosis. It also helps us to assess the fracture risk for each patient, and also helps us with prognosis and monitoring of the medications that we use. Also, it's important to know that patients that have had a hip fracture or vertebral compression fracture have a clinical diagnosis of osteoporosis regardless of their bone mineral density measurement. So you probably have seen this in your DEXA reports, is the WHO classification criteria for osteoporosis. So they measured this T-score, and there was a big population study to see the bone mineral density in an average healthy 30-year-old adult. And the T-score measures how much your bone mineral density differs from an bone mineral density of an average healthy 30-year-old adult, mostly in the women category right now. So when your T-score is equal or higher than -1.0, we consider that your bone mineral density is normal. When it's between -1.0 or between -1.0 and -2.5 is considered low bone mass or osteopenia. And when it's less than -2.5 is considered osteoporosis. Patients have severe osteoporosis when their T-score is equal or less than -2.5 and they have had a fracture. So in those patients that have low bone mass, we use this calculation called the FRAX score, which stands for Fracture Risk Assessment Tool, that helps us and provides information for the doctors on the fracture risk of an individual patient. It's a tool that calculates your 10-year probability of a fracture, of a major osteoporotic fracture, which include a spine, hip, forearm, and humerus, or a hip fracture. And it uses multiple risk factors that we know are responsive to drug treatment. So this is how it looks like. A lot of the DEXA machines calculated for us in the DEXA report, or we can use this tool online. So as you see, it takes into account multiple risk fractures that are very important, and also the T-score in the femoral neck, but the FRAX score can be calculated with and without this measurement. And it gives us a number, and we know that the recommendation is when the FRAX score indicates a risk of major osteoporotic fracture of more than 20% or a risk of hip fracture more than 3% in a patient that has low bone mass, it is an indication for treatment. Definitely a patient that has had a hip-vertebral fracture is a candidate for treatment, as well as a patient that has a T-score of -2.5. So in spite of the high mortality, morbidity, and economic cost of the disease, is often untreated. And why is that? We note that in the early 2000s, 2006, most frequently we see that there was a decline in the treatment of osteoporosis, and that was because at that time there were reports about two very feared rare side effects, which are osteonecrosis of the jaw and atypical femoral fractures. So we know that these medications that we use have risks, most commonly gastrointestinal, and sometimes some reactions, infusion reactions in the IV formulations, but these three last ones are very rare, and we're going to discuss them in a little bit. We have to take into account the benefits. It reduces the fracture risk, decreases mortality, improves the quality of life, and overall costs for the healthcare system. At this time, I have many patients that have osteoporosis that are very afraid of the medications because they have heard so many bad reports that they could die from these medications, that it can cause a fracture. And there's a lot of misinformation around this. First of all, I'm going to talk about the non-pharmacological treatment. So it's very important to note that there should be an adequate intake of calcium and vitamin D. So in general, we recommend about 1,000 to 1,200 milligrams a day for women over the age of 50 and men over the age of 71. There is no evidence suggesting that taking more than 1,500 is beneficial to prevent fractures. We know that the data suggests that calcium with this supplement reduces the risk of hip fracture. Mostly, there's no clear impact in the lumbar spine fracture risk. And it is important to note also that the dietary calcium should be the first line approach because it's absorbed better. The problem with that is that as we age, a lot of patients develop lactose intolerance, they have high cholesterol, they have other reasons why they cannot tolerate dairy and other foods that are rich in calcium. So a lot of times I think we end up giving half with supplement, half with diet if possible. Also, a few years ago, there were some reports regarding increased risk of cardiovascular disease with calcium, and also a lot of patients stopped taking it for that reason. At this time, there is a lot of data out there that is controversial and seems to be insufficient to instruct patients to discontinue calcium. So at this time, we continue to recommend the use of calcium for prevention and also treatment. Vitamin D is also very important. In general, is recommended to have about 800 units to 1,000 units a day in adults over the age of 50, but some patients might need more. Also, avoidance of smoking and alcohol, excessive alcohol, because as I mentioned earlier, those are risk factors for osteoporosis. Also, weight-bearing exercises are very important because they have been shown to increase the bone mineral density in the spine and hip, and we'll talk about that in more detail in a little bit. And fall prevention. So talking about diet, we know that calcium is the important material helping us building up bones. So it is very important throughout life to have adequate sources of calcium, especially in growing kids and women that are pregnant and breastfeeding. There's a lot of different sources of calcium, especially dairy products, yogurt, fortified foods like cereals, green vegetables like spinach, kale, broccoli, or asparagus, salmon, and others are sources of calcium. Vitamin D is very important to absorb calcium and is made in our skin when exposed to the sun. So especially in the Chicagoland area, we don't get that much sun exposure for around 6 months. And also we're using sunscreen that prevents the activation of vitamin D. So it's sometimes difficult to get adequate vitamin D levels only with food. So supplements are often necessary. So we measure the blood level and we give indications on how much to take. Some patients might need that amount that I mentioned earlier, 1,000 units, which is kind of the most common use dose, but some patients might need a lot more. Also that patients that have gastrointestinal problems don't absorb vitamin D well. So in those patients, it's very important to make sure they have an adequate supplementation. This is a list that I recommend or that I give my patients that has the estimated calcium content of certain foods that are rich in calcium, and you can see it has a serving size so that you can try to calculate how much you eat and try to do your best with food only, which is the best kind of calcium that we have, or if needed to add a little bit of a supplement. Now we're going to switch gears to exercise. So we know that bone impact exercises such as jumping jacks, lunges, and other calisthenic exercises have a positive effect in the bone mineral density. These type of exercises are the kind that make us contract the muscles around the hip, and that's how they improve the bone density. It is important to know that walking is not enough to improve bone density. In studies that have shown that, but we know that patients that do walk versus patients that are sedentary tend to have better bone health overall. So it is important also to continue to be active. Then we have the bone resistant training exercises, which are the weight bearing exercises that have a positive effect on the lumbar bone mineral density. And they focus on all the major muscle groups of the body, focusing more on the strength rather than the endurance. You can do them with free weights or machines. So exercise is very important to do both kinds of exercise, as I was saying, because they have different impacts in bone mineral density. The intensity of the exercise should be based on the risk of the patient. So if they have osteoporosis and they have had previous fractures and other risk factors, then we might recommend lighter resistance. Also, when they have very low T-scores, especially in the spine, it's important not to overload that flex spine because that increases the risk of vertebral fractures. It's important to target the muscle strength. So there should be a higher load with decreased reps, about 8 to 12 reps until you reach muscle fatigue, and ideally 1 to 3 sets. You get the most benefit with the first set. So it depends on the each patient and their different diseases and also exercise capacity. Ideally, 3 days a week should be done with a day of rest in between. So it's very important to have exercise precautions and do the exercise right, because otherwise it can cause injury. So we have at IBGI a program called Bone Health Program that encompasses health coaching, nutritional coaching, and also physical therapy that we recommend to our osteoporosis patients, so that the physical therapists can evaluate the patient, their particular risk factors, their particular capacity, so that they can recommend exercises that are adequate without causing injury. In patients that have osteoporosis and problems with posture and balance, it's very important to focus on strengthening the posterior thoracic musculature and address also fall risk and have correct exercise technique. Many of our patients with osteoporosis have also osteoarthritis or inflammatory arthritis, such as rheumatoid arthritis or psoriatic arthritis. So a lot of times it's important to accommodate or modify that exercise to the specific joint concern, or if the patient has a flare-up. So we tend to avoid in patients with arthritis high impact activity, and there's recommendations regarding modifications for those exercises. So these are some examples of exercises to strengthen the posterior chain and the spine that are important also for posture. Switching gears to fall prevention, in patients that have loss of balance, it's important that they use an ambulatory device such as a cane or a walker, to try to use rubber sole shoes so that they don't slip, that there's no loose objects around the house or carpets. They should have skip-proof bags attached to the floor to avoid falling or tripping. Also, in this time of year, I recommend my patients to avoid going outside because there's very high risk of falling when there's slippery surfaces or icy sidewalks. Make sure that they have adequate shoe wear. Also important to have the stairs and rooms were lit, especially at night. As you get older, patients go to the bathroom more frequently, so that they have a path of light, because a lot of falls happen around that time. Also, if they have difficulty with their daily activities in the bathroom, put grab bars near the toilet or in the shower to prevent also those falls in the shower, which are very common. Now, switching gears to a pharmacological treatment, this is a list of the agents that are most commonly used for treatment of osteoporosis, both in men and women. I'll just show you this graph, which is very complex, and this is just to show you how intricate is the cycle of the bone remodeling process. There's two cells that are important that maybe I'll talk about a little bit with treatment: the osteoblasts, which are the cells that build that bone, and the osteoclasts, which are cells that are kind of eating at the bone, so that there's a fine oil machine here regenerating our bones. And this happens normally throughout our life. After menopause and with diseases and other factors, this cycle is disrupted, and that's why there's bone loss. So a lot of the medications we have available target different areas of this cycle, and we'll talk about that in a little bit. So we'll talk more about the biphosphonates, which are the most common medications prescribed for osteoporosis, and you probably heard a lot about Fosamax, which is alendronate. Then we have Actonel or risendronate, Ibandronate or Boniva, or zoledronic acid or Reclast. These cells, what they do is they block the osteoclasts, which are those cells that kind of eat up the bone. That's why they're called anti-resorptive. And they reduce the risk of vertebral and non-vertebral fractures. Some of them have IV formulations, most of them are oral. And the most frequent side effects for the oral medications, they can cause heartburn and gastrointestinal irritation. Some of them can cause joint pains and flu-like symptoms. And rare side effects include low calcium, osteonecrosis of the joint, atypical femoral fracture, which I will discuss later in our talk. So we know that these medications tend to linger in the bone for a while, even after discontinuation. And that is the basis that for a drug holiday, maybe you've heard about that from your doctor, and this is unique for this kind of medications. We know that after discontinuation, also the benefit of a decrease in risk of fracture also persists for a few years. It's important to know that also biphosphonates have other beneficial effects that are probably not heard of. They decrease the risk of breast cancer, colorectal cancer, gastric cancer, stroke, and overall mortality. So they're not that bad. Now I'll talk about denosumab or Prolia, which is another very commonly used medication. It's also anti-resorptive, but it works differently than biphosphonates. It also reduces the risk of vertebral, hip, and non-vertebral fractures, and it can be used in patients that have kidney dysfunction. Usually the bisphosphonates, we try not to use it in patients that have significant kidney dysfunction. Also causes similar side effects, and it's important to know that when the medication is not given when it's supposed to, the effect is rapidly lost, and there has been reports about rapid decline of the bone mineral density with increased risk of vertebral compression fractures. And actually, we have seen several cases of this throughout the pandemic because a lot of our patients were fearful of coming to the office to get their medication when they were supposed to. So with this medication, there should not be a drug holiday without any additional treatment. Now we'll talk about a different class of drugs, the anabolic agents. We have teriparatide or Forteo, and abaloparatide or Tymlos. These are analogs of the parathyroid hormone, which is the normal hormone that induces the bone building process. They decrease the risk of vertebral and non-vertebral fractures. We usually do not use them in patients that have hyperparathyroidism or that have had history of radiation therapy. Some side effects of these medications, they can cause nausea, dizziness, joint pains, sometimes leg cramps, and elevated calcium. There's a rare side effect that it's only in this class of drugs, and is osteosarcoma, which is bone cancer. It's a black box warning for these medications. And they saw these cases mostly in their early studies in rats. This is a daily subcutaneous injection that is very costly and can only be used for 2 years of the lifetime, but they're very effective at increasing bone mineral density. The newest kid on the block is Evenity, which is most recently approved medication, romosozumab. This medication is special because it has dual effects, both anabolic and anti-resorptive. It does reduce the risk of vertebral fracture and is 1 year of treatment, monthly injections. Most common side effects that can cause also injection pain, headaches, and sometimes muscle pains. And there's a black box warning regarding potential increased risk of heart attack and stroke, which is also not recommended to use in patients that have these conditions. So I'll just show you this graph about how much all these medications reduce the risk of vertebral fractures, hip fractures, and non-vertebral fractures. So it's pretty significant what they do for our bone health. And despite of that, as I told you earlier, we saw initially after those reports that the especially for biphosphonates, the prevalence of use decreased significantly. It's thought that this was secondary to starting a drug holiday, but also because of fear or prescription or use from those medications. So I'll switch gears now to those rare but feared side effects of this medication. This is osteonecrosis of the jaw. So what is this? This is non-healing wound with exposed bone in the maxillofacial area for 8 weeks or more in the absence of radiation therapy. Patients can have pain, swelling, and infection. Most patients that have this have cancer or are on high doses of IV biphosphonates or take high doses of steroids or are on chemotherapy. It's important to note that the absolute risk of having this side effect if related to biphosphonates is about 0.001% to 0.01%, so it's extremely rare. And at this time, the relationship between biphosphonates and this disorder is not clearly established. We don't know if stopping the therapy reduces the risk necessarily, but when patients require invasive dental procedures, we try to talk to the dentist and make sure we hold them for a period of time. Mostly the biphosphonates with Prolia is a little bit more tricky from what I told you earlier about having rapid bone loss with discontinuation. So usually for prevention, we suggest that the patient should continue their routine dental care. Ideally, they should have a close follow-up, and at some point, dentists usually use some prophylactic antibiotics and other mouth rinses. Now I'm going to switch gears to atypical femoral fractures, which is another very feared side effect of these medications. So usually these fractures are symptomatic. The osteoporosis fractures do not give you any symptoms, they just happen. So some of these patients describe dull pain on the side of the leg that most times can happen in both legs. In X-ray, we can see some early changes with thickening of the cortices of the femur. So a lot of times if patients are on these drugs and they start having symptoms like this, we might do an X-ray to evaluate it, or sometimes with the DEXA scan, we can extend the DEXA scanner and do a single image of the femur to evaluate if there's any concern about this potential side effect. We know that the incidence in patients that take biphosphonates of this condition is about 0.01% after 3 years and about 0.1% after 10 years. So we know that it does increase after you've been exposed to these medications for a while, but still the absolute incidence is very, very low. Much lower than the incidence of hip vertebral and other osteoporosis fractures. So we know that about 3 to 5 atypical femoral fractures happen per 1,000 hip fractures that occur due to osteoporosis. We also know that patients that use steroids that have higher weight and lower height are at an increased risk. Also, patients that are Asian compared to other races have an increased risk. And there's some reasons behind that. I think that might be due to the biomechanics of the bone of Asian females. And also there might be some genetic factors that are not clearly identified at this time. We know that usually in women around 65 to 75, the risk is higher compared to those that are older and are on these medications. So I wanted to show you this graph. As I was discussing, we know that as we use biphosphonates for a prolonged period of time, the risk of atypical femoral fracture increases, although continues to be rare. But then it's important to know that after we stop these medications, about 50% of the risk decreases after the first year after discontinuation of these medications, as early as 3 months after discontinuation. So this is the basis for drug holiday that I was mentioning earlier. Still, I wanted to show you this graph that the risk of having a major superior fracture in females that have low risk, moderate to high risk is much, much, much greater compared to the potential risk of having an atypical femoral fracture or osteonecrosis of the jaw. Also, these other graphs are to show you that about 265 hip fractures happen per each atypical femoral fracture that could be related to biphosphonates. And about 1,200 fractures could be prevented per atypical femoral fracture that is associated with 3 years of biphosphonate exposure. So I hope I convinced you that This is a rare side effect that it can happen, but patients should not be discouraged to get treatment for osteoporosis based on these rare side effects. We do take that into account in patients that require treatment for over 5 years, and sometimes we switch medications or we do these drug holidays, as I was discussing. With that, I leave you with a picture of my beautiful Bogota, where I was born, and I thank you for your attention, and I hope this was helpful, and now I take any questions that you may have.
All right, and I am back too. I'm going to pull up my list of many questions. So we'll go through them. I tried to take out ones that were that you had already addressed. So I'm going to try and go in the best order that I can. Someone asked, could you expand on your earlier comments regarding enlarged abdomen and lung capacity or shortness of breath?
So sometimes patients that have osteoporosis, when they have a lot of vertebral fractures, they get all curved up like this. Oh, let me see my camera. So you can see if this is the spine and this is the abdomen here, the abdomen kind of comes out. So it pinches on the lungs. So the lung capacity goes down, as you see. So it makes very hard for them to breathe. And also, if you're all hunchback like that, it's difficult to get your air in. So patients that have severe osteoporosis and multiple vertebral fractures also have trouble breathing, and that's just from restriction of the lungs. You're like crunching the lungs with the bone.
That makes sense.
What that means.
Okay, thank you. Does collagen strengthen or build bone? If I add collagen peptides to smoothies, would that be beneficial?
So at this time, there's really no data suggesting that collagen builds up bone. I know that now is recommended in patients that have osteoarthritis, in which there is degeneration of the cartilage. Also, that has not been shown to increase the cartilage in that situation, but there are some reports that it helps with pain. So as I said earlier in the talk, osteoarthritis and joint pain are not symptoms of osteoporosis. Those are two different conditions. So
Right.
I don't think is necessarily beneficial for osteoporosis, but I recommend to my patients that if they would like to try that and see if there's any benefit, mostly for their joint pains, they can do that. I don't think it's harmful in any way.
Thank you. That makes a lot of sense. In your opinion, what is the best, like, do you have an opinion on the Fosamax versus Boniva versus Prolia, et cetera, or is it specific to each independent person who comes to see you?
Yeah, so it's not that one is better than others necessarily. Within the biphosphonate category, those are kind of the first line treatments that we use for the most part. So in patients that have osteopenia or that have like early osteoporosis without any fractures, we might use the oral biphosphonates, and especially like Fosamax, Boniva, or Actonel, and especially if patients can tolerate that, because a lot of patients, depending on the age, have heartburn and other problems. So we prefer to use a parenteral formulation, like an IV or a subcutaneous injection. But it depends. Some patients, when they come in and they have multiple fractures, we might want to be more aggressive and use medications such as the anabolic agents that I mentioned, like Forteo or Tymlos. So it is very variable and is very tailored to the patient. And as I mentioned, there's many risk factors. So if somebody has 10 risk factors versus someone that has only one, we might be more aggressive or not, depending on that, and also on their conditions. I also mentioned that patients that have kidney dysfunction might have a relative contraindication to the biphosphonates, depending on their degree of kidney dysfunction. So we might choose Prolia in those patients sometimes. So yeah, so it's very targeted to each individual patient.
Yes, and that makes sense. So if someone's doctor is recommending one particular medication, it's because of that person's specific situation.
Correct.
Got it. All right. Someone else asked, I've heard caffeine leaches calcium from bones. Should I be giving up coffee and tea if I have severe osteoporosis?
To my knowledge, I'm not familiar with caffeine being related to osteoporosis. There are patients that have kidney stones have an increased risk of leaking calcium in their urine, and that can lead to osteoporosis, but I'm not familiar with the other foods kind of precipitating osteoporosis.
Okay, thank you. That's good to know. What is your opinion on algae cal?
So I know there's a lot of plant-based calciums out there claiming that they're better absorbed. At this time, there's really not scientific evidence that that's necessarily true. I tell patients that we know that calcium citrate is better absorbed rather than calcium carbonate. That we know for sure. So with the plant-based calcium, I think it will be okay, probably about the same. So it's mostly about absorption and tolerance. Some patients that take regular calcium carbonate, Oscal, and others like that, generic calcium, can have upset stomach sometimes or constipation. So when they switch to these other formulations, they can be better tolerated, I think.
Ah, that's good to know. And are there certain foods, you mentioned certain foods, but are there other foods that are good, have high numbers of calcium in addition to things like milks and yogurts and things like that?
So I probably will refer back to that slide that I put for different foods that are rich in calcium. We know mostly dairy is the one that has had the highest content of calcium, but there's a lot of fortified foods, especially milks that are non-dairy, like almond milk, for example, that has a little bit higher than regular milk, but it depends on the brand. So it's important that
Ah,
check your nutrition facts. There are other milks now that, as I was saying, a lot of patients, as they age, they become lactose intolerant. There's a lot of different milks, cashew milk, coconut milk, and others, oat milk. So most of those do not have additional calcium. So that's why I tell my patients you have to double check on your brand, because some coconut milks, I know that they have calcium in it. Some oat milks do too, but a lot of other brands don't. So it depends.
good
So
to know.
it's important to check those nutrition facts. We know that just cow's milk, I'm sorry, does have calcium in it automatically. You don't have to check for that. But for those
Gotcha.
other nut milks and things like that is ideal. Almonds per se have a lot of calcium in it. But usually having several handfuls of almonds is something that people do a lot of times. But I do recommend, if they snack on nuts, to try to do almonds. Salmon is one of the fishes that have also high calcium intake, and the same as spinach, kale, broccoli, asparagus. And in less amount, you will have to have a whole lot of spinach to have your daily intake of calcium. So that's why I put together that information, so that depending on what you eat, what you can eat or not, then you can get to that threshold of 1,000 to 1,200 milligrams, if possible, with your diet only. I find that most of my patients achieve about half of that with their diet. So that's what most people are taking, about 500 to 600 milligrams a day of calcium.
Excellent. That's a great answer. Thank you. And I'm sure that was when I was writing down questions as you were going through that slide. And I'll just point out to everyone too, so that everyone knows, this program is being recorded and will be on the Illinois Bone and Joint Institute website, as well as on the North Suburban YMCA website. So you can then access that slide again and look at it, take a picture of it, and save it, so that you can, when you go to the grocery store, you can learn what Dr. Rodriguez recommends that you eat. Excellent, thank you.
Sure.
Okay, is it possible to reverse osteopenia?
So with the medications, as I was saying, we monitor, and there's improvement in general of the bone mineral density. So rarely, very rarely goes back to normal. But we know that with the treatments, even though your bone density remains stable with the, when we monitor bone mineral density, we know that the bone quality continues to improve. So stabilization of the DEXA scan, the T-scores, and the bone density is actually success of treatment. So it's, I guess, a false expectation to see those numbers be in the normal range.
Gotcha. Okay, thank you very much. All right, you've answered so many of the questions. So you talked about different exercises that were good. Someone asked, are there any yoga positions that are contraindicated in patients with osteoporosis?
I think those, I forget what it's called, the inverted positions where you're like putting all your pressure in your head. I forget, inversions, I think they're called. Probably are not a good idea because they put a lot of strain in the spine. Other things that I recommend against doing for patients that have mostly weak bones in their spine is to do overhead activity or overhead weights, like, you know, trying to put things over their head or
Like a
doing
shoulder press or something like that.
yeah, so ideally, that's recommend, you can do shoulder presses on a machine that is more stable. So with the free weights, is a little bit more tricky because sometimes you compensate with your spine. So that's why those exercises, if you have significant osteoporosis in the spine, might not be very ideal, or with significant weight. So if you notice that you're losing your posture and you cannot hold the press, then you should lower your weight or avoid those overall.
Great, thank you. That's very helpful. Someone asked, is a rebounder or mini tramp, are those exercising on those beneficial when you have osteoporosis? So I think they're talking about bouncing on a mini trampoline.
Okay, let me see, bouncing on a trampoline. Well, I guess that could be considered impact exercise. So I think that would be beneficial, as I showed you earlier with my slide of jumping jacks and things like that, that work
Right.
on the musculature in your hip area that can increase the bone density in the hip area. So just, the important thing is to be cautious about falling because
Yeah.
that's a problem with osteoporosis, to avoid fall. So I guess yes, from some reason, but jumping on a trampoline kind of made me scared for falling for the patient.
Fair enough. Okay, thank you, thank you. Is it possible to get rid of a dowager's hump? You were talking about that curved posture.
So patients that have vertebral fractures, sometimes they meet certain criteria to do kyphoplasty or surgery, but and pretty much they inject some cement to make those vertebrae stronger and a little bit thicker. But usually when the patients have that hump, it's already because they have multiple fractures. So I don't see spine surgeons correcting that.
Gotcha.
Because the bone is very fragile, so it doesn't hold the screws necessarily. But obviously we always have our patients check with our spine surgeons and everything, and they determine who's the best candidate for surgery or other procedures. But that's not something that is really commonly done.
Got it, and that makes sense. Okay, thank you. The question was, and I'm not sure if you addressed this, I might have missed it. How does estrogen or estroidal therapy enter into the prevention of osteoporosis?
So a lot of times patients that have early menopause are put on hormonal replacement therapy. So that is actually approved for the prevention of osteoporosis. However, because of all the potential risk of cancer, breast cancer, and others, that has fallen out of favor. So in my practice, I think I see patients that are older, and I just leave that to the gynecologist. So
Okay.
that's more of a question with the gynecologist, because I know there's a lot of new formulations that are lower in estrogen. I tend to see that they're not using that very commonly anymore, only for osteoporosis. Mostly they're using it if the patient has significant menopausal syndrome symptoms like hot flashes and others. But that's something that is addressed with the gynecologist in general.
Got it. Okay, thank you, thank you. Are DEXA scans indicated for those over the age of 50 who have risk factors as a matter of course? So are DEXA scans indicated as a matter of course for those over the age of 50?
So I think I took that slide out probably, but yeah, so indications for DEXA scan, patients that are 65, females, 65 and older without any risk factors, or 50 years and older with risk factors. So as you saw, many risk factors that we have. So if you have one of those and you're over the age of 50, there's a clear indication to do bone density for screening. And for men over the age of 70 or over the age of 50 with risk factors usually.
Great, thank you, thank you. Okay, and I'm going into the ones that were recently, someone asked about water aerobics. Is water aerobics beneficial for people who have osteopenia or osteoporosis?
So technically, water aerobics takes a lot of the resistance off, and there is lighter on the joints. So as I was saying, I don't have any data supporting that because also when you're in the water, you take a lot of the gravity, which is what we want to do in those weight-bearing exercises. But as I was saying, walking and being active in general is something that we see an improvement in general with bone health. So it doesn't necessarily correlate with increasing the bone density like the other kind of exercises do, but in general, it's good for your health. It's good to, continue to be active, to have that muscle strength that is important for posture, to prevent falls. So there's a lot of other added benefits to just being active. And I know a lot of patients, as they're older, they like the water aerobics because they also have osteoarthritis or other kinds of arthritis. So it's gentle on the joints. And I'd rather that someone does that rather than not do anything.
Good answer. Thank you. Great, great. All right. And someone asked where they could find the food chart. And I mentioned that you can find it on the IBJI website. I'm just going through the most recent questions. Let's see. I think actually you've covered most of them. So thank you very, very much, Dr. Rodriguez. Any other parting comments that you want to give to people?
Don't be afraid to start your treatment if it's indicated for you. Okay, I think you should trust us that these medications are well tolerated for most cases. And if you have had a fracture, it's very important to see a rheumatologist or your primary care and get tested for osteoporosis. Because as I said earlier in my course, it's a costly disease, it's a common disease, and it could be deadly. So it's important to get diagnosed and treated appropriately.
Wonderful. Thank you very much for your time tonight. Thank you all for joining us tonight. I want to let everyone know that on March 31st at 7 p.m., we have Dr. Adam Young coming to speak, and he is going to be talking about interventional pain management. So join us next month for interventional pain management. Dr. Rodriguez, thank you so much for all of the great information. Her information is right here on your screen. You can take a picture of that and you'll have it. Or you could access it on the IBJI website or on the North Suburban YMCA's website. Again, thanks, Dr. Rodriguez.
Thank you very much thank you for having me tonight. It was really fun, and thank you again. And any questions, and if anybody would like to contact me, you have my contact information. I'll be happy to look at you, take care of you.
Wonderful. Thank you.
Thank you very much.
Have a great night. Bye-bye.
Bye-bye.